Good morning. It's the 21st of June 2020, Sunday. How are you all doing? It's good to see a lot of you here. So we're due to start another 4-5 minutes, and it's going to be an interesting morning. As he said, as we've notified, we're going to be talking about colorectal cancer. It's a very common problem affecting lots of people. We'll go into the details around, when we start at 11 o'clock. So it's good to see you all. Hi, Wahid. Post a hello in the chat box, ask questions there, and what we'll try to do is answer some of the questions as we go, but most of the questions I'm going to be answering after the show, so that I could answer all of your questions in one by one. Okay, so hello Vimala, hello Nizam, hello Philomena, hello Varghese Joe. Good morning to see you all. So I hope you're all keeping safe. It's important to still follow all the advice given by the governmental agencies. Most important is wearing your mask. Please, if there's one thing which you're going to do, wear a mask. It's so important. Wash your hands, and these two things will protect you and your family. It's very important at this point in time. It's good to see you all. Please keep posting, writing on the chat box. Hi Sutopa, hi Tanvir. Another few minutes, 5 minutes to start. So today we're going to be discussing a very important topic. I want you to share this video. I'm going to share it on my wall as well. Please share it. You could do a watch party, because that'll spread the word, because it's important to spread the word. Okay, so please share part. So today we're going to be discussing a very important topic. Excellent. Okay, so just 2 minutes. I'm just going to let's get that started. Just 2 minutes. I'm just going to okay, so that's good. Let's get that started. Okay, that's great. So we got another 2 more minutes to go. Hello Bharati Narayanan, hello Farin, hello Kazi, hello Fatima, hi Rebecca, Binti. Okay, that's great. So we got another 2 more minutes to go. Hello Bharati. Okay, so hello Mr. Sanjeev Kumar Bardhan. Hi Natasha. Hi Madhumita. Good. So 2 more minutes to go. So important topic, very important topic. I want you guys to put on a watch show, or at the end of the show, please share it with your friends and family, because colorectal cancer is going to be a huge problem for all of us. If we pray that we don't get the problem, but if we know of anyone who gets the problem, we can help them by educating them, and they can seek help and advice early, and then we should be able to cure them. So it's very important to spread the message. So why we do this every Sunday is it started in lockdown period. I think it's the best thing that I look forward to it every Sunday morning to meet. Most of you have become my friends. Hi Chandramohan, hi Nizam, hi Ziban, hi Krishna Rupa Majumdar, hi Ankit Dutt. So but it is a community which I want you all to grow, where every Sunday morning we can discuss anything. It doesn't need to be colorectal, but that's all I know in my life. So but we could discuss other topics. Next week I'm thinking probably we're going to get a dietitian, because diet is so very important. So I'm thinking if we can get a dietitian to come and chat with us like a Zoom call and answer some of your questions about diet, and I think that will be very interactive. So next Sunday morning will be about diet and GI, and I think it will be a good program. So that's next week, right? So we're almost there. 1 more minute to go. Keep sending in your messages. Hello Srinivasan, Krishnan. Hello Anik, Hassan. It's important to get this interaction going, and what you learn. If you have any questions, just keep asking me, because it's difficult to answer all the questions, but I will try to answer most of them. So almost ready there. So this COVID-19, we are in the middle of it. I think we sort of a little bit understand what's going on, but the most important thing is that we wear a mask and wash your hands. That's the two things which you have to follow. Hello Usha Balasubramaniam. Hello Ashwani Gupta. Hi Ritesh. Good to see you all. So I want to keep this as interactive as possible, otherwise it gets boring. So it's 11 o'clock, so let's start. So this week we're going to talk about colon and rectal cancer. Okay, we don't like the C word, but the problem is it's becoming a common problem, and I want you to understand the basics of it so that you don't have to fear it. The important thing you have to understand about colorectal cancer is that it's curable, right? It's curable. That's the great thing about all the other cancers we've done. We see in the body. Colorectal cancer is one of the betters. If you look at a silver lining, in all this gloom, that you can cure colorectal cancer. But the important thing is you have to reach out early. Okay, so we're going to talk about colorectal cancer. What are the symptoms? What are the signs? How it should get tested, and then what are the tests which are available, and what are the treatment options? Okay, so colorectal cancer is the third most common cancer in the world. Okay, amazing. Okay, so as much as possible, don't message me directly because it becomes difficult to answer all of you. Just message in the chat box in the show itself. Okay, so third commonest cancer in the world. Okay, but it's fourth commonest cancer in men in India, fifth commonest cancer in women in India. So it is quite a big problem. Every year, around 60,000 new colon and rectal cancers are diagnosed. Can you imagine what's going on here? We are worried about, we've had about 3.5 plus COVID cases, and about 10-20,000 deaths so far, sadly. But if you look at the incidence from COVID, if you look at the incidence of colorectal cancer, it's 60,000 in India. If you take the entire subcontinent, we are talking almost 1,100,000 colorectal cancers in India, Bangladesh, Pakistan, Nepal, Sri Lanka, this entire region. So you could see that many cancers, and the death rate, unfortunately, in India, for example, is around 35,000 people die from colorectal cancer every year. Isn't that scary? Isn't that scary? Yeah, it is. But the good thing is, if you come early, we can cure the problem. So it is a huge problem. It's a huge health problem which we need to deal with. So we have to be aware. If you are aware, then if someone gets symptoms, then we can reach out to them, right? Okay, so it is a big health issue. Now we know the numbers roughly, and the problem in India is patients come late. Okay, because the symptoms for colorectal cancer and symptoms for piles, for example, rectal bleeding, anal pain, these small can also be the same for colon and rectal cancer, right? So important point. Symptoms for colon and rectal cancer are similar to that of symptoms for piles. So what happens? So patients will think, oh, I think I have hemorrhoids or piles, or maybe a fissure, some constipation problem. Ignore it. Go see the pharmacist, local pharmacist, or ask someone, for a friend. They'll say, oh yeah, piles, just take some medicines, and they will ignore the symptoms. Every month, I see one or two patients who have been ignoring their symptoms and they come at a late stage. That's the problem. So if you come at a late stage, it's very difficult to cure the problem or cure it beautifully. Do you understand? Yes, we can do lots of things, but we can, you can avoid a lot of things if you come early, right? So important thing is symptoms are there. Now, do we have a screening program in India? The answer is no, because the incidence of colorectal cancer is not as high as in other countries. Hi Kongon. Compared to say in the UK, you get 35 new cancers per 100,000. In India, we get 4 per 100,000. Right? But we still get 35,000 cancers in the UK, and we also get 35,000 cancers in India because of our population of 1.4. So, but the mortality or death rate is higher in India because we come at a later stage. So important is to reach out early. So what are the symptoms of colorectal cancer? As I said, it can be very similar to hemorrhoids or piles. So you can get rectal bleeding, anal pain sometimes, change in bowel habit. Your bowel can become constipation or diarrhea. Okay, so it can go alternate. So you can have weight loss, you can have anemia, or you can notice a lump in the abdomen. Now, change in bowel habit and constipation and rectal bleeding, you can have it normally also. The problem, you should take it seriously when you have these symptoms for more than 6 weeks. 6 weeks. If you have symptoms for 6 weeks, right? 6 weeks. Rectal bleeding, anal pain, change in bowel habit, which could be constipation or diarrhea, anemia, weight loss, then you should definitely see a doctor. Okay, it's very important. So when you see otherwise, because if you do small changes, you get better, and there's no other one episode of rectal bleeding and change in bowel habit usually settles, then you don't need to worry about. Okay, but if it's more than 6 weeks, you should Mr. Raman Sir, please don't keep messaging because it's disturbing me. So what happens is it's important to see, that's what the flow goes. So the important thing is to watch the symptoms for 6 weeks. If you watch the symptoms for 6 weeks, if it's all fine, then okay. But if it's persistent for 6 weeks, you should need a specialist, and that's very important. It's very, very important. Okay. So those are the symptoms. What are the signs? Signs again are very similar. You can notice anemia. You can see weight loss. You can see tiredness. Those are the signs which patients will usually complain of. So what are the tests you can do for if you have persistence? First thing to do is, when you have these symptoms, is to go see a specialist. So when you go see a doctor, you obviously go through the history of how long you've had these symptoms, and then if you have any pre-existing conditions like diabetes, high blood pressure, these are routine questions. But important questions they will ask you are, have you got any conditions like ulcerative colitis? Ulcerative colitis is inflammation of the colon. Long-standing ulcerative colitis can cause colorectal cancer, so you need to know that history. Then they will also ask, the doctor will also ask, or the specialist will ask you if there is a family history of colorectal cancer. Now that's very important. So remember these are very important points. If there is someone in the family, say father or mother has had it, then the children are at risk. Okay, so if the father has had it, then the mother doesn't have the risk. Okay, but the children have the risk. So if you have brothers and sisters, all of you need to be screened. If your mother has the risk, then again it goes to the children. So it doesn't go between mother and father, it goes between the children. Okay, so if it's in the family, then the cousins. So that sort of things so the family needs to be screened. It's very important, because every now and then patients come with the father, for example, comes with or a person comes with colorectal cancer. We treat them, But sometimes we don't concentrate on the family because the family carries the risk. So they need to be screened. So at the when you're doing the one little point has to be made when consulting the patient itself. Have you got brothers, sisters? Have you got children? All of them need to be. You have to make a point to say, or the doctor has to tell them that at some point they all need to be be seen in the clinic, have a chat to see if they had symptoms. They need to be screened now. If they don't have symptoms, then you stratify the risk, but they need to be screened in due course. Okay, so that's very important. So we've taken the history, we've gone through your medical history, we've gone through your family history, we've gone through your habits and what medications you take. And once it's all done, then you need a physical examination. So you need an examination of the abdomen, and the most important abdominal examination to feel for any lumps and all those things. But the most important examination is to do a rectal examination. So a lot of the times this is missed out. Okay, now that can lead to a lot of problems if it's not examined properly. So many times some of the doctors may diagnose hemorrhoids. Unfortunately, it does happen. They say it's piles. Sometimes they undergo operations too. So if it is a 30, okay, let's put it this way. If it's a 20-year-old with rectal bleeding and some hemorrhoid tissue are there, okay, most likely to be hemorrhoids. If it's a 60 plus or 70 plus, they have symptoms, most likely they could have something more serious, because as you get older, you get all these problems. So the important thing is they need to get screened. But remember this important point. Colorectal cancer is also starting to affect the young people. I am operating on young people as young as 18, 19-year-olds. Okay. So it's very, very important that if somebody's got some symptoms persistent more than 6 weeks, they should get a screening, rectal examination start with, but also a sigmoidoscopy at least. Okay, sigmoidoscopy or plus or minus a colonoscopy depending on the symptoms. So everybody should be screened. Okay, a rectal examination clinic is very important. It's no two ways about it. A good clinical examination. After that point, then the doctor decides whether you need, if you are young and there's no other risk factors, and obviously he examines the anus and there is an obvious problem, then you do a short colonoscopy or sigmoidoscopy, and that's good enough most of the time. But if there are more symptoms, as change in bowel habit, blood is mixed with stool and things like that, then you need a full colonoscopy. All right, a full colonoscopy. It's very important. So plus if you're older, if there's family history, a colonoscopy is a gold standard test. Okay, gold standard, because you can look inside. It's a safe test. There are some risks, but if done well, it should be completely safe. But colonoscopy is a gold standard test. Now, the good thing is you can look inside and you can take biopsies and send it to the lab to have it checked. Okay, so some people may be frail, old, and in that case we can use a CT scan as well to assess this. So that's those are the two most important tests is colonoscopy. So as I said, first examination in the clinic, then depending whether it's a sigmoidoscopy or short colonoscopy or a long colonoscopy, and then a CT scan depending on what the doctor finds. And if it is so those are the initial tests. So sometimes for a rectal cancer, if it's not sometimes for a rectal cancer, you will need an MRI scan as well, because the MRI scan is also we call it a gold standard for rectal cancer, because it gives the idea of the tissue, the exact nature of the condition better compared to CT scan. For rectal cancer, MRI is a very good option and gives a much clearer picture when you're trying to assess the tumor. So we looked at initial assessment in symptoms, we looked at initial assessment, examination, and what are the tests? We talked about sigmoidoscopy for simple screening, but if you're talking the context of colorectal cancer, the best test, gold standard test is colonoscopy, right? Now, people did not fear it because you can have it under sedation, under anesthesia, or without it, depending on your choice. So, sorry, I'm just saying hello all to everybody. I'm here. Hope you can all hear me. Just put a thumbs up in the box so that I know what is happening, because we're doing this all by ourselves, which is great. So we've looked at the tests, which is great. Then we will look at colon and rectum, because slightly different treatment. So we looked at some of the anatomy in the last few sessions. So the colon is a long tube like a question mark. At the end of the colon is the rectum and the anus. The colon is almost between 1.5 to 2 meters long, which is like a question mark, and then the sigmoid colon, and the rectum is 15 centimeters, the anus is 4 centimeters. So that is a long tube. So if you do all these tests, and so the tests show that they identify a growth or a tumor in the tube, the colon rectum tube. The biopsy is taken. And the biopsy is taken, and it goes to the lab. Normally, it takes about 4 to 5 days for the test report to come back. In the meantime, the CT scan will be done. The CT scan report comes back, and then you see the patient in the clinic with the scan report, the biopsy report, and the MRI scan if it's been done, if it's a rectal cancer. Okay, good. So sometimes patients ask me, sir, can we do a PET scan? Now, in our country and in the subcontinent, PET scan is used widely for all sorts of reasons. If you look at the guidelines itself, PET scans are not required for primary cancer. Okay, they're usually required only for follow-up of cancer. You know, I know when you had the cancer done, and this, you know, when you're coming under follow-up, then you can do a PET scan to see if any new cancer come up. Okay, so but you can do, suppose you have advanced cancer initially, then you can look at in the primary first stage when you first go to the doctor. Then you can do a PET scan, because it can show you things which are outer or more clearer. Because how the PET scan works is, let's put it simply. The CT scan you've seen, it looks as black and white images, and with the higher quality CT scan, you get pictures to see clearly, and a specialist can read it better. That's how it works. In a PET scan, depending on activity like cancer, where there is a lot of, let's put it, say, a lot of activity. That's the simplest way to put it. You know, hyperactivity, because the tumor cells are, you know, working overtime to, you know, destroy something. So if they give a dye, for example, or a special marker, it lights up like a little light bulb. Okay, so you see it like a spot, and that is how a PET scan works. So sometimes things which you can't see on a normal scan, you can see on a PET scan. Okay, so that is why it's usually useful to follow up. Initially can be done if you're suspecting advanced cancer, and some units have to do it routinely. So depends on each institute what they do. You know, generally speaking, these are the general guidelines for you. Okay, so we talked about PET scan. So the report comes, and then the biopsy report shows that it can show normally it shows an adenocarcinoma. That's the commonest type, adenocarcinoma. Okay, that is the tumor of the inner lining of the colon tube. Okay, or the colon or rectum. Okay, now, so what do you do next? Then you look at the CT scans to see if the tumor is in one area, small area, or it's starting to spread. Okay, normally the tumor spreads from the bowel wall or the colon wall. Imagine the colon is a tube. It starts from the wall, stage 1, through the wall, stage 2, outside the wall, stage 3, into the lymph glands. Okay, lymph glands are these little let's call them like little sort of gate points. You know, I'm sure most of you know what lymph glands are, and you know, and then they reach the liver. Okay, so stage 1 is in the bowel wall, stage 2, you know, outside the bowel wall, stage 3 is in the lymph glands, and stage 4 is when it's reaching the liver, when it's like stage, you know, it's really spread. So you're looking at the different stage. So stage 1 for colon and rectum, usually the treatment is surgery. Usually, okay. So if it is a colon tumor, if it's not spread anywhere, then you see a surgeon, and then depending on what type of you know, technique the surgeon wants to use. So I routinely use robotic surgery, because I think that's the advanced technology now that's available, and that's our gold standard now, and people do extremely well. So depending, you can do open, you can do lap, you can do robotic, depending on the surgeon's experience, preference, and the advantages which the patients would like to have. Minimally invasive surgery, less pain, less bleeding. We'll talk about the technique later. Okay. So if it's a colon tumor, it's fairly straightforward. You discuss with the doctor, you discuss the surgery. The doctor will explain to you what are the advantages, the risks for any surgery. So let's look at risks for any surgery. So with risks for any major surgery, colon or rectal surgery, is when you perform surgery, is pain. So that's why if you do minimally invasive surgery like robotic or laparoscopic surgery, the cuts to get inside the abdomen, to remove a piece of bowel and then join it back together. So that's what we do. So if there is a diseased bit of bowel or a tube, you remove that with some healthy tissue, send it to the lab, and then get two healthy ends of tubes of bowel to join it together, and then it works normally. Okay, that is how I'm talking about colon cancer normally. Okay, so the two is joined in. Now, to do that, if it's open surgery, you have to make a big cut, and so obviously it causes more pain, infection rates, hernia rates, bleeding, tissue recovery. Everything is slow. So generally, and there is evidence to say, some people will argue that with open you can look inside. All that is, I don't believe it personally. The evidence is there to support that. It depends on the doctor's experience and what the patient wants. And personally, I would recommend minimally invasive surgery, laparoscopic. I think robotics at the forefront or cutting edge of what we're trying to achieve of safe surgery, less blood loss, quicker recovery, less hernia. So I think minimally invasive robotic surgery is very good. So pain. So we're talking about what are the risks. Pain, I said. Pain. So if you make small cuts to get inside and less tissue damage, so there is less pain. So patients recover better. Infection is a risk, but again, if you make small cuts and do minimally invasive surgery, the chance of infection is very less. We'll give you a shot of antibiotics also at the time of surgery, so the risk comes down very much. Risk of bleeding. Now, it's there with any major surgery, but obviously with more experience the surgeon is, the risk is less. So that is what all of you have to do. You have to do your research, because I'm sure if you want to buy a news, Netflix or a TV or a phone, you do your research. So similarly, your doctors and the hospital and the service as a team, you should do your research to see who you're going to get your treatment done. It's very, very important, because that the more experienced the team is and the surgeon is, the better results you will get, because that evidence is there around the world and it is all there. So you need a good team to take care of you. So we talked about pain, infection, bleeding. So these are all things. Now for pain you can also have an epidural, but with to reduce the pain, but with minimally invasive surgery the need for that is becoming very, very less. So the next important, or the most important, significant, which is very rare, is an anastomotic leak. Now this is important thing you need to know. So when you join two tubes, imagine a water pipe. Okay, so let me just take this tube. This is a tube. Say the tumor is there. I'm cutting that tube and then I'm joining two new ends together. So when I join the two new ends together, something can leak. Okay, so imagine a water pipe. You're cutting and then joining together. Then you put something like an M seal. Now you can't do that in the bowel, so you stitch it together, staple it. The chance of an anastomotic leak is about, for colon cancer, is about 4 to 5%. Okay, and that's within less than 4 to 5% is acceptable. So you need to know that. So anything less than 5%, the chance of that happening is very less, but it's an important risk, anastomotic leak. With more experience the surgeon is, the chance of that happening is less. So you can ask your surgeon, what are your anastomotic leak rates, what are your infection rates. These are the things which I want you to ask when you go approach your doctor, wherever you are, whichever country is important. You need to have that knowledge, because that's what is going to safeguard you and also ensure that you get quality care. Okay, so those are the things which pain, infection, and we discussed all that. So for colon cancer, if it is not spread anywhere, it's early stage, or if it's stage 1, stage 2, maybe stage 3, even then, if it's localized, then you remove the tumor, join it back together, and then patients usually recover in 4 to 5 days and they're out of hospital. Then the report comes to the lab. Then you will see what stage the tumor is, and then you will be referred to a medical oncologist who will advise you whether you will need further treatment or not, which could be chemotherapy. This is extra treatment. Now, I'll come to chemotherapy. Suppose if you, at the initial stage, if they say the tumor is, there's lymph glands, lot of lymph glands there, and they may be spread to the liver, then you may go for palliative, not curative, because if you try to remove colon alone at that stage, if it's spread everywhere, you can't cure the disease. So that way, in that stage, you give chemo first to reduce the, or kill the cancer cells, and then maybe surgery at the latest if it is feasible. So the important thing is to know the stage. Then ideally we'll go for surgery, and then based on final stage, go for chemo. Now, please don't fear chemo. There are excellent doctors available, excellent treatments available. I know. First thing people are, sir, you'll lose hair, or Tamil mudi kottiduman, all those things can happen, but less these days, because the treatment or the medicines have become so specific and less side effects, so you do not fear it. And the important thing is to cure yourself. Okay, so colon cancer, remove the tumor, join it back together. Based on stage, you may get more chemo or not. Okay, so hopefully you understood what colon cancer is. Now we're going to go into rectal cancer, because I think that is a big area. Now, all you guys are okay? I hope this is not too technical and you're able to understand. Please say yes or thumbs up if you understood most of the things I've told you so far. So that will reassure me that, otherwise I'll have to go step down to re-explain these things. I hope you understand what I'm trying to say. Just put a thumbs up in the chat box so that we understand what's going on. Yeah, I'm not seeing any messages. You guys okay? Yeah, shall we move to rectum? Great, excellent. So let's talk about rectal cancer. Now, rectal cancer is a whole different ball game, because I think for me as a colorectal surgeon, apart from all the hemorrhoids, piles, which all I do, colorectal cancer is my specialist interest, and robotic surgery is another area which I really concentrate on. Now, the rectal cancer is a very, very specialized area of surgery, and I hope I hope the very best for all of you and all your family. And if somebody unfortunately should get that in your family, friends, please do your research, do the due diligence, as they say, find the right team, the people, because if done well, you can completely do a great job, cure the problem. Okay, so I'll tell you why it's different. So the rectum is 15 centimeters, and it's very close to the anus, which is below that. So when you do a finger examination, go through the anus, which is 4 centimeters, and the rectum is 15 centimeters. So imagine the colon tube, which is like a big thing. If there is any bit of colon which needs a cancer, I remove and join. It doesn't have a big difference. You'll have some disturbance in the motions, but it will usually settles down nicely. But the rectum is where the motion is stored and then expelled. Now, if you have a tumor there, then we have to remove part of the rectum. Okay, so then that's going to disturb the way your rectum and your anus functions, and that is seen in a lot of our colorectal patients. Almost 50-60 patients per people, or the percentage of patients who undergo rectal cancer surgery will have some disturbance, which can be mild to severe. But if you have to maintain the normal route, that is a compromise. Okay, now let's talk about rectal cancer. So again, symptoms for rectal cancer are similar: change in bowel habit, rectal bleeding. That's why I keep telling you, please, you should not ignore rectal bleeding for more than 6 weeks, or change in bowel habit. Particularly one symptom which really worries me is when patients complain of rectal bleeding and mucus discharge, like a pink mucus discharge, which has been persistent. That's a telltale sign for something, inflammation or a tumor in there. Please tell your friends, tell your family if they had mentioned, just let the alarm bells ring. Change in bowel habit, rectal bleeding blood mixed in motion, mucus coming, like, very jelly type stuff coming in the, very fast motion, telltale sign for a rectal tumor or inflammation or a cancer. So please get it checked. Okay. Also, patients may have the blockage, bowel blockage. So, again, anemia, weight loss, all these things. So again, you have to see a doctor. Important thing is a rectal finger examination. There is there's a phrase in one of our textbooks called Bailey and Love, which we used to study in surgery, that it says if the surgeon doesn't put a finger in the rectum, he has to put a foot in his mouth. So basically, what it means is it's such an important thing to do a rectal examination, because if you can easily find it, confirm it, or at least it will show you signs of blood or mucus, which will at least low and mid rectal tumors can be felt. So you can diagnose half the rectal tumors if you do a good rectal examination. So you should insist, your doctor should do it. Ask him to do it. It's very, very important when you have these symptoms and you're going to see a doctor. So again, the treatment for that or the tests or again colonoscopy. Sometimes the tumor may be large, you can't allow it to pass the scope. Then you may have to just take biopsy and come out, but most of the time you'll be able to. Then you do a CT scan. But in this case, an MRI scan is a gold standard. It clearly shows a beautiful picture of where the tumor is, where its location, and important whether it's trying to invade or starting to spread. Now, based on that, then the treatment option becomes, treatment is planned. Okay, so if it is an early tumor, you can still perform, particularly with an upper rectal tumor. The rectum is 15 centimeters, 555 centimeters. Okay, upper, mid, and rect. If it's upper rectum or upper rectum and sigmoid, yes. If it's not big one, you can remove the tumor, prime surgery. But most of the tumors we see in our practice are mid or low rectal tumors in young people, bulky tumors, locally advanced. So most of them unfortunately will need some treatment prior to surgery. Okay, most of them. So how do you identify these people? 1, by examination. 2, by scans you do. 3, the MRI scan will tell you clearly what is the stage of the tumor. If there are lymph glands are positive, I told you lymph glands is where it spreads. So please understand that for rectal cancer, there are 2 or 3 important things which are going to be critical. Okay, 1 is to identify what stage your tumor is. Okay, and if your tumor is slightly advanced or low or bulky, whatever, then you will need treatment prior. Now I told you colon cancer, if most of the time you remove the tumor at surgery and then you join it, and then based on stage you give chemo. Unless it's really spread, then you give chemo first. For colorectal cancer, primarily most of the time, majority of the time, the treatment will be preoperative chemo and radiation. Okay, what that chemo and radiation will do is it shrink the tumor. There is enough evidence over the last 10 to 20 years that rectal tumor, if the nodes are positive and if it's slightly starting to spread, they should have you can give it post-operatively also. But imagine you remove the tumor and join to health, and then they look at the tumor is large and the margins are positive, not fully cleared, and then you go give radiation. It doesn't work properly, and chance of the tumor coming are high. So it is almost illegal to do surgery first in these locally advanced tumors. Okay, around the world you have to give preoperative chemo radiation first. You can, because the chance of tumor recurrence goes down big time, goes down from 50%, right? Okay, I'll give you the numbers in a minute. So that is one. Now if you give, then the technique of surgery, so I'll come to that in a minute. I have to tell you this in a sequence so that you understand what happened. So 20-30 years ago, if you look at rectal cancer, if you get rectal cancer 30-40 years, let's say, 50% or 60-70% will get the tumor back because they just removed the tube. got it out. Okay. About in the 80s, a professor called Bill Heald, okay, Bill Heald in Basingstoke in the UK, UK where I also trained, in our region, in the southwest of England, in a Basingstoke hospital. Professor Bill Heald popularized a technique called TME. I know it's technical, but all of you should know it because this is the very basic of your care, if or your family or friends who should get it. Total mesorectal excision. Remember this. I know it's technical, but just keep it. TM in a mind. TME. That is a technique of removing the tumor with some fat and the lymph glands. I told you, I keep telling you about lymph glands because they are the key. If you just remove the tumor, leaving the lymph glands behind, then you may leave some tissue and then the tumor comes back. Okay. So the key of a good operation is to remove the entire tumor and the fat with the lymph glands in it out. Okay. So that is the key technique, TME. So this happened in the early 2000s. They called the Dutch TME trial, where they said, okay, let's see if we can do what we've been doing all these years or do this technique. Okay. What they found is immediately that cancer recurrence rate dropped from almost 50-40% to 10%. Okay. And then they started giving radiation also. Okay. And then the Swedish rectal cancer trial. So these are, you don't need to know, these are technical bits, but these two trials, in this trial they gave preoperative chemoradiation prior to surgery. Okay. Some radiation and some medicines. Basically then they found out that the chance of tumor coming from it was 50-60, or something like that, to almost 2 to 3%. Preoperative chemoradiation and good surgery made that almost 2 to 3%. So now what is becoming clear is colon, if it's early, moderate also, you take it out, join it back. If it's advanced disease or if the lymph glands is involved, you give them chemo. So surgery is the first line, unless it's very. In rectum, majority of the time you will need preoperative chemoradiation and good surgery, TME surgery, done by a well-trained surgeon. Very, very important. That is where you need to do your research to find your team. It's all about your team. Also, as one Mr. Sinan Shukur, I suspect he's a doctor because he's talking about MDT. Now, MDTs are multidisciplinary teams. Okay, surgery is not a one-man sport anymore. It's not about me anymore. It is about a team. It is a bunch of doctors working together to take care of you. It's so very important. Okay, so those days of I'm the greatest surgeon, all gone, right? Yeah, I've learned surgery. I'm a technician. I do my job well, but there is another person in my team who also does another bit of the operation, another bit of, maybe I do the most difficult bit, but we all work together. And then in the MDT, which is a multidisciplinary, you need to ask if if there's an MDT in the hospital or the doctor's part of it, are cases being discussed in it, because the oncologist, surgeon, your radiologist, the X-ray guy, the cancer guy, the medical cancer, all these guys sit together, look at your reports, and then they say, yes, this is what it is. This is early tumor. It doesn't need any treatment. We can go for surgery first. All cases, colon or rectum. Or this tumor is large, in mid-rectum, low, young man, whatever you need to have chemoradiation prior, because there is always a temptation to do surgery early. Patients will pressurize, surgeons will pressurize. I'm being very honest here, for all sorts of reasons. It could be timing, it could be whatever, patients coming out of, but this is your health. You have to understand that. Majority of the surgeons will advise you that you need a preoperative chemoradiation depending on their local practice. But the gold standard, what is done is that for mid and low rectal tumors, advanced tumors, locally advanced tumors, you get preoperative chemoradiation for a long course for 5 weeks. Then we wait from 8 to 12 weeks. 8 to 12 weeks for the effect of the radiation to all work, and then surgery at the time of 12 weeks. 8 to 12 weeks is what we are doing in our practice, right? Now, this is very important, because what the chemoradiation does is, one, it shrinks the tumor. Also, see, if the tumor is in the mid or low rectum, lot of centers will say, will remove the rectum on the anus and give you a permanent colostomy where the bag sits. It is a debilitating surgery, but it may be the best thing because the tumor is a large one and you can't. But some majority of the time the tumor shrinks, and the anal muscles are preserved, and we may be able to remove it and join it back together. I know of several of my patients whom who come to me. We do lots of these operations. Some of them I'm not able to join it back together because the tumor is large, it's involving the muscles, and we have to have them removed and permanently. But majority of the time we can join them back together, give them the normal route. But again, as I told you, 50-60% of these patients still have this urgency and frequency because you're given radiation, you've replaced something God has created or nature has created and try to put back. So it's never perfect, but you will still have control, you will still be able to use normal route. So 90-95% of the time you're able to join it back together, even if it's low, 2-3 centimeters from the anal verge after chemoradiation. Okay, so coming back to rectums, so we've done the staging, we've said, okay, we've discussed now MDT, which is very important, chemoradiation, multidisciplinary team. Ask for your MDT, that is your audit. This is your own audit before you do surgery. How great is that? Think about it. So we have an audit at the Apollo Main Hospital for the last 3.5-4 years. It has been around the world. In the UK, it's where Europe was the first where they started MDTs, which was standardized there. Then the US has adopted it, and we have adopted in the last 3-4 years. We do a lot of work with our colleagues and collaborators, Professor Stephen Wexner from the US and Professor Manish from the UK, and Delia Cortez from Madrid. So we do a lot of work on this. So on the multidisciplinary team working, because what it does is we as a group make a collective decision for the patient, because at the end of the day, that's why we are here, and for the trust you place in us, we have to do our best. It's so very important, because I may not have all the answers. I learn every day. I'm being very honest. Of course I do make mistakes, but it's less because I've been doing this for a long period of time. So when I sometimes not sure, or can make little errors, which is possible in any profession, any job, that's when this MDT is your audit or your backup to ensure that yes, I am going to the best team, but I have also have reassurance that they have a multidisciplinary team which sits together and have gone through the data and they've all agreed, and I think that gives you so much, gives me reassurance that I'm doing the best thing for my patient who has come from all parts of the world. So it's very important that MDT is a part of the process, and it's become such an integral. So we do one a week, every Friday morning, 8 to 9 at the main hospital. So I'm very proud of that for the Apollo management, which helps us support that that formal meeting, because that's where you ensure guarantee and quality, and that's one of the things which I go back to the time when I first met Dr. Pratap C. Reddy, the chairman. When I came back from England, I wasn't too sure where I wanted to work. So he said few things. He said, like, Venki, you need to we need to start screening, we need to start subspecialized work, we need to do robotics. These are the things which are going to change, and multidisciplinary team working. So this was 2012, we are in 20. So I was very lucky to have a mentor. I keep talking about it. You need to have mentors. You need to talk about these things, because teamwork. There is I've just seen Dr. Sudarshan Raman, who we were very unlucky not to have in Chennai, who spent some time in Chennai, UK trained doctor, as now works in Birmingham, a very fine human being. So those are the kind of people who are part of this MDT. So it's so important to get this group together. So in my group, there's Dr. Sudipta Kumar Swain, there's Asfar Ahmed, there's Dr. Zeran, Dr. T. Raja, Dr. Ratna Devi, Dr. Ruchita. Who else is there? My pathologist, very important, So, Dr. Sunil, and a few people I missed, I'm sorry. But the pathologist is so important because I can claim I'm the best surgeon in the world. Easy enough. I can go right on Facebook, come online, come live, and say that I'm the best surgeon. But the pathologist has the report of every tumor I remove, and he goes like, "Hey Venki, this ain't," because that never lies. Okay, so the pathology report, yes, it can be, but what we've done is to ensure that quality of that report is standardized internationally. We follow the same thing, and so that we have the same reporting done as it's done abroad and here, and we've seen that our quality of work is improved. Our pathologist is saying, "Yeah, Venki, this is good," and maybe that's, then we say, "No, this was challenging in that spot, and that's why it looks difficult," or maybe next time you need to go a bit more tissue, and that's how a service improves. And I'm so proud that we've worked so hard for more than 3 years now with this MDT group, and we're hoping that we can spread this service across the city within the Apollo. All the other Apollo units also do it, but we have it more formalized, I would have thought, and I'm looking forward to help this team grow. And so MDT is very important. That's the bottom line. Otherwise, I keep talking all this, sorry. So rectal tumors. So we've got the MDT. We've said, okay, preoperative chemoradiation, 5 weeks. Patients have to have the radiation. Usually it's about for an hour, I think, every day, Monday to Friday. Saturday, Sunday is off. So 5 weeks they have to go through that treatment. Okay, so you can have it done locally, or you can have it done where your main hospital is, or you can go back into your hometown, have it done, and then come for surgery with your surgeon. So different combinations. You have to find a choice which works for you. Ideally, if it works in the same environment where you're having surgery, the oncologist and the surgeon all work together, and you will have a better outcome usually. Okay, so it is all teamwork, as I say. So we have to work together to get the best outcome for you. So we've done that. So chemoradiation 5, and then you have a 2 to 3 month break. Very important, because you can't, if you operate early, the outcomes are not great. So I often people come to me and say, "Doc, I had surgery, I had some radiation." I had surgery. This is what the gold standard is. And a percentage of people, remember, a percentage of people, this tumor will disappear. Okay. Now that is a problem, because now these small group of people, 25% who complete tumor disappears, people come and ask me, "Sir, why don't we just not do surgery?" Difficult question, because around the world there is a group which follows that, but it is part of a trial. Now if you have that, then every few months you need to have MRI, biopsy, scans. It costs a lot of money, and it's not practical in our country. That is one issue. Second, it can be only part of a trial. Okay, so, and 25% of the people who seem to disappear, the tumor comes back, and then it becomes a bit difficult to treat. So current understanding is that we give chemoradiation 5 weeks. Short course chemoradiation also an option in some people, smaller tumors. In our situation, long course chemoradiation 5 weeks, break for 2 to 3 months, and then surgery is the. So when you come back for surgery, you will have a restaging, like a CT and MRI, to look if the tumor is nicely shrunk. If it is still big and it's everywhere, then there's no point doing surgery. Then you just need for palliative chemotherapy. But if it's shrunk and all that, sometimes locally it may be a little bit attached to a local tissues. That comes out beautifully with surgery, so not to worry with that. Okay. So surgery itself, as I said, so we have another 10-15 minutes. So surgery itself, as I said, don't worry, keep posting the questions, very important. Thank you guys, I'm not ignoring you. I will answer all of those questions individually, personally, because if I start answering now, I'll miss the flow, because I can't complete the entire topic. So I'm going to answer each one of you, and I really appreciate your time and energy to participate, because I learn. I also correct some of the things which I keep telling you if I'm right, wrong. Anyway, so surgery wise, it can be open surgery, laparoscopic surgery or robotic surgery. Now, there is argument among surgeons which is the best technique. Now, you remember the TME, I told you, total mesorectal excision? It boils down to that. Okay? You need to find a surgeon who can do TME very well, and it does it repeatedly and is a high volume surgeon. That's what it is. Not someone who does once in a while. That's like, driving a race car once in a while. You're not going to be a champion in that. Does that make sense? So what you need to do, wherever you are, you need to know you have a high volume surgeon in a high volume center who has a good supportive team and who has an MDT to support it, so that whichever patient is there gets the best treatment, like we have at the Apollo hospitals, which we've done so well over the last few years with the good support from all the management and the doctors, and the support staff, right from the guys who are in theaters, and in my colorectal nurse, Sister Madhak, she's been with me for how many other years now, and she is the front line. She is the service, and I just I'm hide behind her technically, and that little sister, not saying she's little or anything, she's like a dynamo. So she is the one who, people like her, who make our service great, and we all work as a team. But what I'm trying to say is, it's important to have the team. The team is everything, and the highly skilled bits which we do are part of it, and the patients get the final outcome. So you need to find that team which provides you that in a safe environment, who are willing to do the best so that you get the best outcome. So coming back to surgery, the TME is the bottom line is that. So you need to find that service who can provide that safely in a safe environment, who do that repeatedly and have got outcomes data. So that is going to be the future. So you could walk into your doctor's office and say, "Doc, give me your results for the last 3 years." You should be able to do it, and that's the future, because that will, and your doctor should be able to give you that, because what, that data is there. They should be able to give you, and that gives you the confidence. Yeah, I'm not going to X, Y, and Z. I'm going to X or Y or Z, and X has given me his data, and I know, because that is very important, because this is your life and this is our work, and it's important that we do the best for you. So going to which technique, open is fine, as long as you understand what is happening and the surgeon is comfortable, but he's doing the right technique. It's great. Yes, it is bigger cut, more pain, slow recovery, more blood loss, whatnot. So, but in the last 10-20 years, we've been in minimally invasive laparoscopic surgery. But personally, in the last 5 years, I've used only robotics. I don't use any other technique, because I think it's changed my life. It's changed our patient's life, and many of my patients will vouch for it. What we found that is, it gives smaller cuts, less pain, quicker recovery, less blood loss, less damage to nerves, which control, particularly in rectal cancer, which control urinary function. So cancer clearance has become standardized now. Everybody, that's a basic minimum. Come on, that's what it's all about. But functional outcomes. So imagine a 40-year-old, not 40-year-old, let's say an 18-year-old. I've operated so many of those young men and women who have these things. So if I have to do a rectal cancer surgery and I remove the tumor, and there are important nerves going around it, and if I can see, because robotics give me 3-dimensional view, 10 times magnification, less tissue damage, and wristed instruments which are so fine that you can go and pick on little tissues, and so that the tissue damage is less. There is evidence in the literature to show that the chance of these nerve damage is less with robotics. So your nerve preservation is better, so you have better urinary function, anal continence so that you don't leak, and sexual function. So it's very important, because with radiation and all anyway there's some damage there, but if we can preserve these nerves, most of the time it will recover. And then, because you can remove the cancer, but if you damage these nerves, you condemn a young man or woman to a life, because I want them to get back to normal life, and normal, have a family, have a kid, it's a huge challenge, and we have to help them. And so if we can use technology to improve their outcomes, and why not? And I think we should all try to do it. So in our hands, we've seen that the cost of robotics is same as laparoscopic surgery. It's less blood loss, it's less tissue damage, less hernias, less nerve injury, and less conversion. Compared to laparoscopic surgery, it's 1/5 the chance that you can, because the operation is so difficult that you convert to open operation. The chance of the robotics, because of its articulation and advanced technology, it goes into very difficult, awkward positions and still gets all these things done. And chance of a conversion, as they say, is very less with robotics. Okay, and I also find that where you're able to do more reconstructive procedures. Now, I also have to tell you that there is evidence that technology helps, and also specialization helps. If you look at the evidence, and I'm not going, this is not a technical talk, but if you are colorectal trained, or if you do a lot of these colorectal procedures, if you could be general surgeon but doing lots of colorectal surgery, or if you're colorectal trained, your outcomes are going to be better than non-colorectal trained. Okay, your cancer clearance, your cancer outcomes, everything is going to be better. Going back to that story which I keep telling you, or told you earlier, about designing a race car. Once you do it once in a while, you're going to crash a car. But if you do every day race car, or it's like, say, Sachin Tendulkar bowling, or Shakib Al Hasan, he's an all-rounder. These guys, but Shakib Al Hasan is a batsman. Tendulkar is a batsman primarily, but they can also bowl. They can take some wickets. But if you do only batting, your records are going to be much better. You're going to be a master at it. So the question is, very few all-rounders exist. Okay, so we still do have some great surgeons who are all-rounders, but going forward, it will be that technical surgeons who do very few operations, who do it very well in high volumes, will be the future and will be getting the best outcomes, so that at the end of the day, the patient gets the best outcome in all this. So we've talked about, so going back to rectum, so more and more we're able to remove the tumor, very low tumors, and join it back. You may need a temporary bag for about 1 or 2 months, and then we can close it, and normal route is re-established. So we'll talk about LARS. LARS is a low anterior resection syndrome, where you get urgency, frequency with after a low rectal tumor operation, whichever technique you do. Then depending on which paper you read, 40-50% get. That's a compromise, unfortunately, and but we have some programs which will improve these things. So we're going to restart that program in due course, so that these patients benefit. So we will be in touch with that. So I think I've given you a brief of what happens, and in our own practice in the Apollo Main Hospital, our robotic colorectal program is one of the busiest in the country. We've done the maximum amount of cases, which I'm very proud of, because we have a great team, the MDT, the surgical group. We all work together. That is why we are able to achieve these volumes and results. And so, the credit should go to them. Obviously, I do head it. That I do take the credit for all of my team members. But as I said, it's a team sport, and it's very important. And I think what I want you to understand and remember is, don't ignore your symptoms. Rectal bleeding, change in bowel habit, weight loss, anemia, any of these things for more than 6 weeks, you should get it checked. Rectal examination is very important. Colonoscopy is a gold standard. Colorectal cancer is curable if detected early. Screening is very important. Colorectal cancer is becoming common in young people. Young Asian males are more affected. Rectal cancer is becoming more common in them. If tumor is very early, endoscopically can be removed. For that, you need a specialist center. Otherwise, you need to have surgery. New technology is changing the way we look at perform surgery. So in this COVID period, we did a rectal cancer tumor on Thursday morning. He had surgery. Obviously, he got admitted a few days before, did the COVID test. Thursday morning, 10 o'clock was the operation, touch wood. Sunday today. He said, hoping, he's had a tumor, he's had removed, he's got a low joint and he's got a temporary bag and he's out of hospital. Touch wood. I'm just giving you that the benefits of, a teamwork, advanced technology, robotics, and a hospital system which can support. We have a high dependency unit if required. It's not an ICU. It's just high dependency where surgeons and physicians manage it. Just giving more care. With the nurses. So it all boils down to one: patients being, or families or public being aware. Don't ignore your symptoms. And if you should get symptoms, get it screened. And if you should get screened, find something. Find the appropriate team, surgeon, MD team, multidisciplinary team, which can take care of it, look after it, and achieve the best results. Technology is changing. We are, it's everything's going to change. I'm talking to you every Sunday morning, sitting at home. You're around the world. It's fascinating. It's fabulous. And similarly, robotics. I want to finish that. Robotics is socially distant surgery, because if you look at it, the surgeon is sat in a console at a distance. The robot is next to the patient. The rest of the team is slightly away. Every movement the surgeon performs in the console is reflected in the patient. If he doesn't move, the robot does not move. And our infection rate is already low. Which too soon to be published, is lower compared to published US data. Imagine this. We achieved this even in pre-COVID days. Think about it. We could achieve it even now, even in fact with the extra precautions we're taking. We could be 100% hopefully sure that we can have a safe environment in spite of the COVID crisis. Maybe, I tell people that, these are things which we should do. And COVID has accentuated best practice, safety, and technology and its use at a speed which we can't even understand. So I think in all this gloom, and I hope for all the people affected that they get better, and the people we've lost, we pray. We could say a silent prayer, but look at the bright or the silver lining and all these things. It helps us to connect. It's given us time to do that. I'm going to be doing this regularly, so that we could talk. It could be same thing, but at least a few patients, somebody is going to benefit from it. Technology will change our lives for sure, for the better, and I hope you all will stay safe. Take all the precautions, wear your masks for the next 3 to 6 months at least. Wash your hands regularly, and I'll see you soon. Next week we're going to talk about diet and the gut, and I have a special guest, and I will post about it soon. Take care, and I will answer all your questions in the chat box soon, later this afternoon. Take care. See you soon.